Good afternoon, everybody. The onset, let me thank Nerosa for giving me the opportunity. Respected chairperson, seniors and friends, talking about tuberculosis of foot and ankle. We've heard about spine and hip, but foot and ankle is rare. And here is this one example. This is a US gentleman, US citizen actually, Indian origin, who came to us with pain and swelling in the foot and ankle area for 2 months. He was seen by the US foot and ankle surgeon, and they did a CT scan, and they found a lytic lesion, and they diagnosed this as multiple myeloma. Somehow, since he was an Indian, he came to us, and we got an MRI, and this was the picture. Nowhere near the multiple myeloma, there was involvement of the joint and the bone, and we did a CT-guided biopsy, and it was tuberculosis. So this is how an atypical foot and ankle tuberculosis presents. It is less than 10% of the osteoarticular tuberculosis, and it affects all the age group. Unlike hand, which affects the children, here we have affection from 6 months to 85 years. You have literature on that, the various case reports on so there's no age predilection here. The problem here is unusual sites, varied presentations, and can mimic pathologies like anywhere else. So diagnosis is always missed and delayed, and that is a problem in osteoarticular tuberculosis in foot and ankle area. The radiology is not very helpful, and again, when you take a culture, again, it is not very commonly available. Clinical presentations, early stages are very non-specific pain, joint swellings, limited range of movements. It is only during the late stages we get this deformity, but at that time you have already missed the bus. Mittal et al. Described this 5 radiological types seen in X-rays. The cystic type, one of the most common type, whereas there is this lytic lesion, most commonly seen in the calcaneum also. There are this fleeky sequestrae, we call it as a coke-like sequestrae here at times seen. The second is a rheumatoid type of lesion. Here you get a complete coalesced mass, completely osteoporotic. Many times you diagnose this as a Charcot foot or a rheumatoid foot, and many times there is a midfoot collapse. The third more common variety is a subperiosteal lesion, wherein there is a scallopic lesions in the juxta-articular area. And if the scalloping lesion is happening in either side of the joint, then it's called as a kissing lesion. And this is also seen in this tarsometatarsal area more commonly. The spina ventosa, as was described in the hand, also is seen in the foot tubular bones. It's because of the successive layers of the periosteum new bone, and gives this effect of spina ventosa. And this is seen more in the children. Now, coming from the X-rays, you have the CT scans now. CT scans do give you a much more detailed destructive details about this destructive phases, and also helps us in the subchondral changes, to identify the subchondral changes, but it does not help us in getting the soft tissue problems changes. It is not helpful in that. But again, CT scan helps in getting a perfect diagnosis in the right place. The investigation of choice here is an MRI. It picks up the problem in a very early stage, even from as early as 6 to 12 weeks. And we can see the soft tissue as well as the bony problems in the MRI. So if you have a suspicion about foot and ankle tuberculosis, then you should get an MRI to get an early diagnosis and start early treatment. The other tools for diagnostic tests like MON2, the other tests like biopsy, culture, they're all helpful. The problem here only is about the culture in foot and ankle. Most of the time, you don't get the culture positive. Martini et al. Classified this, gave us stages of tuberculosis. The stage 1 is involving the synovium. The stage 2 is the classical tuberculous osteomyelitis, but without involving the joint. Stage 3 is one joint, and stage 4 is multiple joint. This helps in the prognostic evaluation of the patient. And as we have been hearing about the treatment, this also is the same. chemotherapy is the main treatment, and multi-drug chemotherapy starting with 4 drugs and then eventually to 2 to 3 drugs from 12 to 18 months. As Dr. Anil Jain was saying, this is same for foot and ankle also. Here are the few examples wherein you can see, this is Professor Dhillon's case. He's got plenty of papers in this, a case of in a child and then over 25 years of follow-up, completely healed calcaneum bone. This is another case, a 14-year-old child with swelling in the foot. Again, as in hand, there is no constitutional symptoms in the foot and ankle area also. And there is a swelling in the calcaneum area. The X-rays was not very helpful, but the MRI completely changes the view. And here you start on ATT. In the CT scan, you can see this is that classical picture of the coke-like sequestrum here inside the lytic lesion. And on ATT, and the patient gets better. So the multi-drug therapy in the early cases helps in complete treatment, but it should be prolonged. You have to educate the patient for an uninterrupted administration of this. Timely ATT with rest, the complete destructive lesion here you can see changes into a normal way. These are the various pictures again from Professor Dhillon's presentations, wherein you can see the lytic lesion. It takes a long period of time, at times 8 to 9 years, but still you can see the lysis, but the things have healed. At times the lytic lesion doesn't go away, but the patient is completely symptomatically free, and you just leave it alone and don't bother about that lytic lesions. The problem today is the resurgence of disease, especially in immunocompromised HIV patients, and the drug resistance, which we've already heard. We have to look around this big problem of drug resistance. And if there is no response in 4 to 6 months' time, then you have to think that this is the resistance has taken place. And at present, almost 5 to 10% of tuberculosis in the joint, in the bones, are involved as multi-drug resistance. In foot and ankle, there are few indications for surgery. 95% would be treated in conservatively, but when there is a draining sinus, or when there is kind of a collapse of a column, or you want to wash out and decompress a joint, or if you have already a deformity and it's a sequelae of that deformity, you might have to do an arthrodesis. So here is an example, a case wherein you have a juxta-articular tuberculosis. Again, after curettage, to maintain the lateral column length, an X-fix was done. Another case, which is mine here, I had to do a arthroscopic debridement of the joint, because in spite of the ATT after 3 months, the swelling was there and patient was very uncomfortable, so I had decompressed the joint, and immediately within a month's time the patient started getting better. This was an ankle, the talar involvement of the tuberculosis. Arthrodesis is the end for the end stage disease, when there is a sequelae problem and severe deformity. You want a painless plantigrade foot, then you think about arthrodesis. A word about tuberculous tenosynovitis. An Achilles tendon or tib post and peroneals are one of the more commonly involved ones with tuberculous tenosynovitis. X-rays will be normal, but there will be a problem about here, and you have to start on ATT, and at times a tenosynovectomy has to be done. So the end, it is uncommon, it is non-specific, so high index of suspicion is required. So you have to be suspicious about the whole thing. The articular involvement is very common, and the more the articular involvement, more damage it is. So you have to make sure that you have to prevent the articular surface as much as possible. MRI in the early stage helps in diagnosis, and treatment is on clinical suspicion, radiology, and histopathology. So you remember, when you see a foot and ankle, it's a time bomb. You can save him, or you can have a problematic foot forever. So you have this 4 basic armamentarium to treat, and if you can do that, you can rest in happily. Thank you very much.